So this is going to be a talk about vertebral augmentation. So the title of the talk is not going to have anything to do with what I'm going to talk about. I decided just to give you a new talk about optimizing treatment outcomes. So this is a talk I finished last week, so it's very up to date. And this is something to try to help you be better than everybody else at treating vertebral augmentation cases. There's a couple of things. People, because the technique is so effective, people get kind of lulled into thinking that they're better than they really are, but understanding the civil engineering of the spine. So I get a CT scan after I do every one of these. I'm not recommending that you do that, but I've learned a lot from this. And that's what this is. This is restabilizing it. So I refer to it as the civil engineering of the spine. The other one is not to forget your doctors. And we do a really bad job about treating the underlying disorder. And I'm going to talk to you about treating underlying disorder of low bone density, right? So if your uncle, grandfather, dad went to cardiologist because he had a angioplasty and stent placement, 95% LAD, and the cardiologist ignored the fact that his cholesterol was 400, you wouldn't be happy, would you? So I know this is a stretch. My mother is a thin Caucasian female of Northern European descent over the age of 65, and if she fell and broke her hip, somebody put a sliding screw and a plate in there and ignored the fact that her T-score is a minus 3.7, I would be unhappy. And I'm not really thinking about the word unhappy either. So, but we do this every day for augmentation. So I'm going to talk to you about a few things. This is mainly focused on how to improve your outcomes and improve treating your patients. We're going to talk a little bit about prevalence. We spoke about that briefly yesterday. I'm going to talk about mortality because this is a single thing that you can do in your practice. The only thing in this group that you do that is demonstrably life-saving and life-prolonging. The only person that's different here is Neil that does two things that are life-saving and life-prolonging. I'm going to give you an analysis of the entire last 25 years of level 1 and level 2 articles in one single slide. And it's color-coded to make it even easier. Then we'll talk a little bit about new things, techniques and developments. Like disclosure slide. Here, we mentioned the prevalence. You go back 10 years, forward 10 years, the osteoporotic patient population doubles. 1960 to 2030 increases 4.2 times. This is the single biggest demographic we have, and hip fractures are twice as common as other fractures, twice as common as spine fractures. And my good colleague Porter McRoberts refers to this as a silver tsunami. So it's coming, and the baby boomers are moving through. And it's not only true in the United States, it's true in Europe, and it's true even to a larger proportional degree in Asia. And so this is, if you don't like old people medicine again, you need to start liking it because this will be the lion's share of people that you will see, the greatest degree of patient population. We do a really bad job about treating low bone density. I treat everybody that comes through, not because I like treating osteoporosis, because it improves my outcomes. In the Evolve trial, our site, in the largest trial ever done, 354 patients nationwide, 24 sites. Our site had statistically significantly better pain, function, quality of life than the other 23 sites combined within the trial using Kyphoplasty. You realize how hard that is to do? So we treat everybody's underlying bone density. Well, a colleague of mine says, well, that's kind of cheating, referring really to the relative risk reduction. If you treat somebody with anabolic bone agents, you reduce the risk of a distal or adjacent level fracture by 86%. That's what he's referring to. I said, well, maybe, but you could prescribe that medication too, you just don't. So this is putting the fit and polish on your practice, all the refinements. This is the Solomon Dell data. This says that 80% of people that have a fragility fracture are not treated for the underlying disorder after that fracture. The difference between a hip fracture and a spine fracture is you can walk with a spine fracture, you cannot walk with a hip fracture. Hip fracture is a prototypical osteoporotic fracture because you fall down, foreshorten, legs in internal rotation. You know it's a fracture. You know the mechanism usually is just from a fall from a standing height. You know a fall from a standing height shouldn't break a normal bone, so your diagnosis is made by definition. And how many people get treated for their underlying disorder after a hip fracture? So Right here, 40%, 2002, all the way down to 21%. We remeasured this in 2018. So remember in 2002, there was no such thing as an anabolic bone age, and now we have 3. We have Avinity, Forteo, Temlos, PTH analogs, and a sclerostin inhibitor. We remeasured it in 2018. You know what the percentage was then? Should be 50, 60, 70, 100%, 17. So ironically, as the medications get better, as we seemingly get more sophisticated, our ability to treat the underlying disorder goes down. And this is associated with incredibly high mortality rates. The hospitalization rates for fragility fractures are bigger than heart attacks, stroke, and breast cancer combined. So it's a really big public health issue. So ironically, as we get better, the treatment rates are declining. And if you were to say one thing about vertebral compression fractures and the underlying disorder of osteoporosis or low bone density, is that it's under-recognized and undertreated. This is also what Easy was referring to yesterday about people missing fractures. So radiologists can think they're the bee's knees. Man, I'm really good until you find out what you're missing. So if you have, this is Gelbach's data that said a fracture on a chest x-ray wasn't even mentioned about half the time. It was only mentioned 52% of the time. And the people that have something that's a defining event of osteoporosis, only about 18% were being treated for it. So if you were to take 2 groups, and this is DEXA data, this is from the NORA study, you may know where this is going already, but if you have 2 groups, one, T-scores less than -2.5, or by DEXA scan, obviously the definition, DEXA definition of osteoporosis. The other group is osteopenia normal. Which group gets more fragility fractures? This group, osteoporotic, or the normal or osteopenic? Should be osteoporotic. Well, let's look at the data. Here's the osteoporotic group, and this is a number of fractures. This is a little bit difficult to see because of the color, but this is number. This is osteopenia and normal. So by far, the greater number of osteoporotic or fragility fractures happens in this group. Lesson, don't worship at the altar of the DEXA scan. It's good for tracking response to treatment. It's good for an overall estimate, but it's a poor estimation of bone strength. Poor estimation of bone strength. Primarily, steroids is a good example. Why are steroids so bad for the bone? Just demineralize it? No. It has an adverse effect on the collagen in the bone as well. That's why it's so bad. And DEXA is nothing more than a 2-dimensional measurement of bone density. It has nothing to do with measuring the quality of bone or bone strength. This is the Beall data, meta-analysis, measured the response to 4 anti-resorptive drugs. I have them listed there. And found an 11% mortality reduction in just anti-resorptive medications. This is controversial at the time. Sign Array came out in the New England Journal article and said, well, you know, if you have an 11% reduction in mortality, maybe we shouldn't be doing placebo-controlled trials for anti-osteoporotic drugs anymore. And you know what? I think they're right. So primarily, the latest trial that finished up is called the ACTIVE trial, Paul Miller's trial. Paul practices in Denver, Colorado. He's the only U.S. site. All the other sites were OUS. So primarily, any drug that's tested against a placebo is conducted outside the United States now because of this data. 11%. It's really big reduction in mortality, pretty significant. And I don't disagree with the debate not to do and compare with placebo. So 11%, what about 32%, 44%, 43%, and the 2 biggest articles, 55% reduction in mortality. These are the salient mortality articles that compare vertebral augmentation, kyphoplasty, with vertebroplasty and non-surgical management. Edmond, Ong, Chen, Zampini. There's more than this. And before you think it's just a United States phenomenon, there's been articles like this, Hong Kong, Finland, Sweden, Taiwan, South Korea, all over the world, saying essentially the same thing. And the reduction, as we mentioned yesterday, today I told a few of you, you probably shouldn't be doing vertebroplasty at all anymore. And that's true, with rare exception. Primarily because vertebroplasty doesn't perform as well as kyphoplasty for pain relief, significantly less quality of life, and on every single one of these studies that's measured, Kyphoplasty has a statistically significant benefit over vertebroplasty for mortality. Every single study, claims-based analysis. Here's the one that we published last year. Kevin Ong was the first author in this. We studied 32 million patients in the entire Medicare claims-based database for 10 years. 2,077,000 fractures. And the mortality benefit not only is profound at year 1, but lasts all the way out to year 10. What is the mortality rate for untreated fractures in this patient population? What's the mortality rate? 85.1%. It's incredible, right? 10-year mortality rate, 85% of people were dead if their fracture was not treated with augmentation. So, some of the insurance companies or some of the recommendations like the ASBMR recommendations, so you need to put them in a brace, give them some pain pills, right? You heard this. You shouldn't treat somebody for 6 weeks. What's that based on? What's evidence for bracing? What's that based on? What about the optimal pain management? Conventional medical management, these are two things that's called. What is that based on? So if you do something radical, like actually look at the data, here's what it's based on, and it really doesn't say that at all. So hard brace, soft brace, no brace. And this is Kim, data from Kim. I have the references down here. No difference, no difference, no difference in pain reduction. Brace, no brace. This is Bailey's paper for 8 weeks. No significant difference. Rezwuska did a meta-analysis, took 5 articles looking for optimal pain management in this. Said a few things. First of all, the evidence is low quality on the benefits of anything, rest analgesics, bracing, opioids, and concluded there's insufficient data to recommend non-surgical management or conventional medical management in these patients. So whenever somebody tells you to brace or do something other than augmentation based on something capricious and arbitrary like timelines that have never been proven, because UCLA RAND paper that we published last year said, based on conventional appropriateness methodology, the expert group, taking 180 scenarios, concluded that time has no role to play in recommending treatment surgical or treatment non-surgical. It's meaning that you can treat the patient at any time based on their symptoms. And there's a list of 7 things in there based on symptoms. Essentially, it has to do whether a patient can walk or not. That's the biggest one, right? My colleague from South Africa says you're either on legs or off legs, meaning you're either up or you're down. And if you're down, your mortality rate is exceedingly high. And it has to do with progression of kyphosis. It has to do with level of pain and disability. So it has to do with symptoms, not timeline. So going back to this, if we no longer do placebo-controlled trials in the United States because of an 11% mortality reduction, what about a 55% mortality reduction, 5 times that? And people call for placebo-controlled trials all the time. The ASBMR just called for that this year. It kind of puzzles me. So really to know, to place the recommendations, the validity of those recommendations, the categorization of those recommendations, I wanted to provide this to you as some background. So things that are pertinent to the treatment of patients with vertebral compression fractures, like the treatment of underlying bone density, and the treatment associated with the outcomes associated with those treatments, you can put this into greater perspective. I want you to have firm footing on your decision-making about what you do and what you don't do, and to know the real data, not just inertia and tradition. There is no 6-week wait before you treat patients. That's based on vapor. It's nebulous. It's mist. There's nothing there. So this is the real data, and this is what you need to know. 2 New England Journal articles, 2009, and I talked to a couple of you about this, and I gave you one salient point for each one of these trials in VERTAS 4. Encourage you to have a podcast on VERTAS 4. It's about 6 minutes. Send it out to you guys if you want. If you find it on LinkedIn or Twitter, I encourage you to listen to that. It gives you the inside scoop on what goes on with these articles. I give a whole hour-long lecture on these articles about what's wrong with the methodology, but I won't do that. What we did do is we noticed that after these articles came out, people started treating less, especially here. This is ground zero for non-treatment of vertebral compression fractures, right? Right, you guys are here? UW, OHSU, right? Terrible. So what we wanted to do is see what happened after this, because it's our perception that the treatment rates were declining, and they were. Before, 24% of the patients were being treated for painful vertebral compression fractures. Excuse me. After this, 14% were treated. That's a big drop. 10% is a big drop when only 1 in 4 patients were being treated to start off with. Okay, is that bad? Well, that was the whole point of our article, was to test the mortality rate before and after the downward trend in treatment to see what effect it had on it. And here's the effect. The number of patients for projected treatment are in this kind of red line, and the proportion, it fell as compared with what would have been projected had the papers not been published. And this is the proportion of vertebroplasty started to drop. Proportion of kyphoplasty proportionally started to come up higher than what would be expected because of a negative article on vertebroplasty. So what else happened? 75,000 people were put at increased risk of mortality. 6,800 people plus demonstrably lost their lives based on the downward trend in treatment. Remember what I told you earlier. What's the number needed to treat to save 1 life in 1 year? 15. NNT is 15. Where did this NNT come from? It comes from this database. This was done free. The database study for mortality was a sponsored trial, sponsored by Medtronic. Thank you guys very much for that. But we noticed that the mortality rate was not only high, it was exceedingly high. And the difference was not only present, there was a big difference in treatment, the downward trend in treatment. And we wanted to boil it down into one number. And so Kevin Ong, the guy that did the paper, did this for free. This is, to calculate NNT is not easy. It's beyond my statistical capability. I'm good at statistics. This is beyond my ability to do this. It requires some sophisticated calculation. The guy did it for free. So it wouldn't be industry sponsored. But remember, the number you need to treat to save 1 life, statistically, for every 15 patients, you're saving somebody's life. So thank you for doing that. People say, oh, there's insufficient evidence. We need more randomized control trials. We need more data. There's not enough data on vertebral augmentation. There is more data on vertebral augmentation than every single other area in spine combined. Every year there's 250 articles that come out on vertebral augmentation. Pop and Estacio did a great meta-analysis in 2011, published in 2012. 27 level 1 and level 2 articles in the English language. Some other jerk repeated this later and found 25 articles in addition to that. That's 52 level 1 and level 2 articles published over the last 25 years. And here they are. This is the entirety of the best quality literature of vertebral augmentation in one slide. And my son, when he was 4 years old, so what do you think I should name the good studies? Well, I'm going to color code this. He goes, green. I said, what about the bad ones? He goes, red, like a stoplight. I'm like, and how many red studies, meaning something performed better than any type of vertebral augmentation, including vertebroplasty and kyphoplasty, do we have? Is there any study that is color-coded red? So number one, there's no negative articles. There's 3 equivocal articles that vertebral augmentation didn't outpace SHAM or fake surgery. All the other ones, all 49 articles, all the rest of them are positive. Some quite positive. The largest trial ever done, a reference to the EVOLVE trial. The average amount of pain reduction in the EVOLVE trial is a 6.3. That, my friends, is better than anything that I've ever seen, except for a study that we're going to talk about here in a second. Registry. So a registry is like the overall picture. A randomized controlled trial is this. A randomized controlled trial is a specific patient treated in a specific institution using specific inclusion-exclusion criteria, using specific instruments, done in a specific way with a specific follow-up. Registry is treat them as they come, using whatever method you want to. Just track your results, right? Registries are great. This is real world evidence. Patient-reported outcomes, and this is just kind of how it happens. One of the things the registries gave us is hip and knee arthroplasty. Used to be, we'd have controversy about a knee replacement. Oh, it's expensive. It's just pain, you know? Why do that? It's too expensive. Everybody's going to be wanting knee replacements, hip. You don't hear about that at all anymore. The reason why? Registry data. Really pushed it back because it proved it wasn't just pain, the debilitation, mortality, other things, bad things would happen. Track the actual cost. What is the cost? What is more expensive, vertebroplasty or kyphoplasty? Yeah, kyphoplasty. Is it? How do you measure cost? So a kyphoplasty kit, let's say it's $3,000. Vertebroplasty kit, $600. Which is more expensive? The vertebroplasty kit. Because if you do something radical like follow your patients longitudinally over time, you'll find that these patients will consume more pain medication. And that's referenced by Kevin Ong says it takes 2 years to make that delta, to have the crossover between what's called the value treatment effect. So our patients continue to consume more health care, more visits. And it takes 4 years in Europe, according to an article by Ansgar Lang. The QALYs, Quality Adjusted Life Years, as measured by NICE, National Institutes of Health and Clinical Excellence, says kyphoplasty is cheaper at 2 years based on Quality Adjusted Life Years. I'll show you a little bit of something with the registry. The registry is done so healthcare professionals can inform patients the best way to go based on real world data. So we had 1,096 patients, 732 patient data set from those 1,096 patients, and the largest registry in the world. This is about twice as large as the Swiss registry, which is the second largest. Here is the demographics. The primary endpoints were pain and function, and the median pain score, median, went from a 9 to a 0 at month 6. The mean pain reduction, the average pain reduction, was a 6.7. So you guys don't do a good job treating patients nationwide. You do an excellent or outstanding job. The Roland Moores went from a 21 to a 7. This is from severely disabled to almost nothing at all. At this Reynolds-Westry scale, it would be 40 points plus, 2 categories. So, kyphoplasty is risky. Don't know if you should be doing that. So, cement leaks. I mentioned this yesterday. Anything that happens in 1 in 4 times is normal and expected. How many cement leaks out of the 24.4% of patients that had it were symptomatic? 0. How many neurologic injuries did we have? 0. The adverse events overwhelmingly are related to sedation, not related to the procedure. Overwhelmingly. So saying this is a safe procedure is not accurate. You'd have to say it's extremely safe to be accurate. Safer than almost anything that we do, intervention-wise. 16% of everybody, 1 in 7 patients, were readmitted. Why? Primarily adjacent level or distal fractures, almost exclusively. When people die from mortality, what do they die from? So we talked about the high mortality rate of vertebral compressive fractures, and it is high. 8.6 times age-matched controls, really high. So what do they die from? Is it fat embolism, like a high-speed motor vehicle accident, fat emboli to the lungs? What do they die from? Pneumonia, 90%. The other cause is DVT with subsequent PE. So they die primarily of pulmonary causes. So what's more expensive, non-surgical management or vertebral augmentation? I gave you the difference between vertebroplasty and kyphoplasty. I'll give you a greater delta. What about non-surgical management? That's cheap, right? Really cheap. You don't do anything. Or do you? What is non-surgical management? Bracing, rest, analgesics, ER visits, imaging, doctor visits. So if you take a look at it, what is expensive? Prompt care. Prompt augmentation costs $6,400. This is from the registry data set. If you delay, and plan A is bracing, rest, analgesics, and if that doesn't work, plan B is bracing, rest, analgesics, you come back with 16 visits, 8 MRIs, 8. So, oh, your back hurts, maybe we should get an MRI. I know what to do there. MRI comes back, yep, fracture's still there. 6th, 7th, 8th, yep, still there. No change in plan, ER visit, finally gets treated. Far more expensive. It's far more expensive doing nothing if the patient is not improving than it is doing something. This is the SAKOS trial. Referenced this yesterday. So 15 investigators, 13 sites throughout Europe, and this was a randomized controlled trial comparing SpineJack against balloon kyphoplasty. This is new data. This was just published this year by Noriega. David Noriega was the senior author on it. Has anybody read this paper or familiar with this data? Good, so it's new, and this is brand new. So, pain function, quality of life, and measurements, and, well, that's interesting. SpineJack, as you saw yesterday, has some knobology associated with it. It's not just a balloon, it's not just an injection. It seems more complicated. Seems like it would take more time. Doesn't. Mean time is about the same. You can say SpineJack's about the same as balloon kyphoplasty, perhaps a little bit less time. And it is a space-occupying lesion. So the jack itself takes up some space. It also reduces the vertebral body. And it reduces it well, but the fundamental point is it will take less cement. So the SAEs, significant adverse events, was one of the primary endpoints. So long story short, no SAEs at all in this trial. So this is the free trial. This is a Medtronic trial. It was done in Europe, and the orange line is non-surgical management pain response. The blue line was kyphoplasty, and this is a 300-patient randomized control trial. This is an exceedingly well-done trial, and there's a big difference between patients that were treated and with non-surgical management, patients who were treated with augmentation. Still, at the end of the trial, there's still a significant difference even after 2 years. So let's look at some other trials. This is the VAPOR trial, Bill Clark's VAPOR trial. That's a sham trial that was positive for vertebroplasty, and his sham was not docking the needle on the pedicle and injecting a bunch of bupivacaine. His sham was injecting lidocaine under the skin, appropriate sham. What about Vertos 2? This was conventional treatment, not sham. Kind of tracks along the same lines as did the conventional treatment for the free trial. I mentioned the Evolve trial. We got a 6.3-point reduction in pain, very profound, largest kyphoplasty trial ever done. This is how you guys do every day, even better than the Evolve trial. That, my friends, is impressive. This is real-world data. So not only does it work well, it works exceedingly well. SpineJack, better. One of the differences between the SAKOS trial was a difference in pain. And so, as I mentioned, statistically significant reduction in pain, although the system is considerably bigger. The 5.8 millimeter implant is a 4-gauge needle, 4. So it's big. So you think that bigger instruments would hurt patients more. They don't. So we have to rethink what gives rise to additional adjacent level fracture. We used to think that you put cement in there, and that causes additional fractures. Some people still think that. The evidence is clearly in. There's been numerous meta-analysis, literally over 100 articles about this. There's no difference. Remember the Cortos, Stryker's Cortos? That was developed, bought from Orthovita, who developed it. It's a combite glass ceramic tri-resin polymer, and it was designed with the elasticity modulus of 7, similar to cortical bone. And it was done to make it soft so you wouldn't get adjacent level fractures. What happens in the pivotal trial? No difference in fractures between cement and Cortos. No statistically significant difference. So if that doesn't do it, well, what does? Well, if you don't treat, and I mentioned this yesterday to some of you, the adjacent level fracture after a fracture of the spine, the adjacent level fracture rate is, even with no treatment, between 20 and 25%. Well, why is that? Well, if you fracture, you put additional stress and strain in the adjacent cortex because of the kyphosis, and because of the inability of the disc to pressurize and transmit intradiscal pressure, stress and strain, you double that again. So the stress and strain primarily in the cortex level above is increased by a factor of 4. That's why people that haven't been treated still have an adjacent level fracture 20-25%. What happens if you treat them with vertebroplasty? What's the adjacent level fracture rate? Between 20 and 25%. What about kyphoplasty? Reduces it more, primarily because the structural change. There's plenty of biomechanical data, primarily from Pat Warden, did some of the best trials. Relman also did this, said kyphosis is a single thing that puts stress and strain in the adjacent levels, not what you put in the vertebral body at all. SAKOS trial showed significant reduction in adjacent level fractures, primarily because it also, and this goes hand in hand, shows statistically significant benefit in reducing or raising the middle and anterior portions of the vertebral body back to a more anatomic alignment. And at the end of the trial, SpineJack patients had 12 fractures in 8 patients, and balloon kyphoplasty had 26 fractures in 18 patients. Highly statistically significant difference. So we're now able to cut the native incidence down to below natural native incidence. One final point. Why do people think that putting cement in somebody, say doing a vertebroplasty, would cause additional fractures at a higher rate? Because this is kind of ingrained. People really believe this. My favorite trial of all time is by Yi, 290 consecutive patients, and found no difference in adjacent level fractures between non-surgical management and vertebroplasty or kyphoplasty, but he measured, he does something different. I thought this was brilliant. He measured the temporal relationship to the fractures in the treated and non-treated arms and found that there was a very big difference in fractures that happened after somebody underwent augmentation. After somebody undergoes augmentation, the additional fractures happen quicker than the patients that have non-surgical management, a lot faster. So you see those fractures. You do an augmentation, patient comes back with another fracture within a few days. Oh, I've done something terrible. I put hard cement in the vertebral body and that gave him another fracture. Well, turns out that's not true at all. But they do happen faster after augmentation. Additional stress and strain more quickly on somebody that has a bone mineral density loss of up to 2% a week in the acute phase of that fracture. So another piece of evidence for prompt treatment. So SAKOS conclusions, statistically significantly better for fracture reduction, pain relief, and vertebral height restoration. So osteoporosis and fractures are both, if you were to say one thing about them, they're tremendously under-recognized and under-treated. Our radiology colleagues do a lot better about recognizing these things, and we need to do a lot better, according to the data from Gelbach. These are exceedingly common. Over 1 million fractures of the spine, fragility fractures of the spine, will happen this year. 160,000 traumatic fractures, 100,000 neoplastic fractures, accounting for tremendous amounts of debilitation. These are very common, and we know for sure that non-surgical management is ineffective. Just know the data. Know Reswuska, Kim, Bailey. Know these papers. Be able to cite them as evidence, especially the meta-analysis on this. Whenever people refer, oh, you should put a brace on them, just understand that it might help a little bit in terms of pain, and that's fine, and that's good, but there's no data that's saying that that is effective treatment for that patient at all. Not only is there a little bit of data, there's a lot of data on vertebral augmentation. There's a lot of data that continues to come in at a clip of about 250 articles a year. There's good mortality data. And now we're about ready to have, as soon as the data I presented to you from the registry, the reason it may not look familiar to you, it's not published yet. It's in process, being reviewed right now. So hopefully we'll have this out as a real world impact. So we have level 1 data, RCT. We have what's essential post-market phase 4 type trial and the Evolve trial. Now we have a registry. So this will put a nice fit and polish on this. And some of the new data on the implants show that it may be better than balloon kyphoplasty. Certainly it did in the SAKOS trial. So I'd encourage you to do that. These are all conclusions. won't really address independently. What I would like to say is people that do augmentation, almost to the person, say, and people that do augmentation plus everything else, almost to the person say that's the single best thing they do in their practice. Right, Easy?
We'll talk.
We'll talk. So in my practice, we do 100 different things to the spine. And it has the best outcomes of anything we've ever tested. We're on our 50th clinical trial. So I would encourage you guys to not only get involved, not only become proficient at doing this, but also to help put the fit and polish on it. These people that are under-recognized and under-treated in terms of everything else, what we've done, we put people through a program. We follow them up for 2 years to treat their underlying bone density, and it's been very gratifying. So people say, I don't have time to do it. I do, and I'll take your patients too if you don't have time to do it. So we take them, we do the conventional follow-up. We do a DEXA scan. We do injection training. This is the anabolics are primarily, they're all injectable. We send them out for home health. That's a G0180. Nurse visit, year 2, another DEXA scan. Year 3, DEXA scan follow-up treatment. I'm counting CPT codes. We get paid for all this stuff, including the home health. We now own a home health company. It was a house that G0180 built. $74, better than a slap in the face though. So not only can it be profitable, our patients demonstrably get better outcomes. So, and keeping in mind, if you have a practice, you want to have a my mother practice, right? Practice you'd be happy treating your mother, assuming you like your mother. I like my mother. She's a nice woman. So put the fit and polish on this. Don't ignore the underlying disorder. Become really good at the civil engineering of the spine. It will benefit you greatly. Know the literature, or at least enough of it to guide your pathway to do the right thing for people and to refute people that are trying to encourage you to do the wrong thing for your patients. And with that, I'm going to end it right there. I'll open up to questions, comments. Appreciate it.
I had a question about something you said with the PT trial, and that patients who undergo vertebral augmentation develop adjacent level fractures more quickly. Is it because they notice more?
So in the acute phase, your bone loss goes up to 2% a week. If you don't treat, the muscle loss is so profound that you lose 50% of your strength within 6 weeks. So it happens fast. The downward cascade is more of a downward fall. So whenever people have a fracture, they remobilize immediately, right? They get off the table, get a little old lady hug, and she's good, right? She's gone, out of there. But keep in mind, she's less strong by far than she was when she had that fracture, because the average age of fracture will be 4 to 6 weeks or more, right? Her bone loss will be profound at that time, and you're putting additional stress and strain on a bone that's really bad. What happens normally is that bone loss will stop. It'll stop after the acute phase and not go down quite as much. So probably the reason for the more development more quickly of additional fractures is because the immediate resumption of the stress and strain that they can still do on an abnormal spine and clearly abnormal muscular strength as well. So combined with the fact that there's a little bit of residual kyphosis left over. The Relman paper said if you use cement that has up to 4,000 megapascals of resistance to stress, to impact, that has far less impact on the stress and strain on the adjacent vertebral levels than does the residual kyphosis, and the difference is significant. The kyphosis is much more important. So if you can treat them early and do a better job, meaning reduce the fracture, you'll probably get better outcomes with less adjacent level fractures, just like we saw in the SAKOS trial.
What's your management of the post-kyphoplasty fractures that happen?
So say that question again?
What's your management of the fractures that are happening after the kyphoplasty? You said they're happening more acute.
Yeah, so I see everybody back. I do the follow-up for my bone mineral density. I use anabolic bone agents. I use primarily, my go-to is Tymlos or abaloparatide now. It's better than Forteo. And then I either follow that with 2 years of alendronate, garden variety Fosamax, based on the Active Extend trial, or I give them a year of Avinity. And I want you to know something. Like, I have patients that are on 6 to 7 months of Avinity after 2 years of Tymlos. I have bone mineral density increases up to 25, 26%. One DEXA category is 10 to 12%. This is more than 2 DEXA categories. This is a lifetime benefit. This is like de-aging your bones 40 years on the DEXA scan. This X is age. Y-axis is bone mineral density, and it trundles down. You've seen this graph, right? Normally with age, it pushes it up. It almost gets it to peak bone mass at age 30. What I'm trying to say to you is within, 72-year-old female comes in, still going at it, doing everything she wants to do, productive member of society, falls down, breaks her spine, T-score is minus 3.7, not an unusual scenario at all, right? If you just pay attention, that person that's destined with a little hypertension, destined to live until her late 90s or later, except when she dies of a hip fracture that you could have prevented at the time you saw her but didn't. If you could take that and give her 25, 26% increased bone mineral density, that de-ages her bones to when she was about 35. So that's a lifetime benefit. So I follow them along doing that. At any point in time, last thing we say to them, if you have any additional back pain, you come back and call us immediately. People come in, we see patients that you think everybody would understand if they have a fracture when they had another fracture, right? They would understand, yes, I have another fracture. My experience, no data on this, but my opinion is about half the patients understand they have another fracture, half don't. And one of the best things, referencing the physical exam paper from Langdon, it's 81% sensitive and 93% specific, the inability to lie flat on your back as a sign for a vertebral compression fracture. Same paper had about the same degree of sensitivity and specificity with closed fist percussion, back of your hand. So Palatine also said transitional pain, standing, lying, sitting, lying, transitional pain, pain with movement. These are the physical exam symptoms of fractures. So my MAs that run my DEXA, if they can't lie flat to do a DEXA scan, they send them over to MRI. I don't even see them. They say, hey, I sent Mrs. Smith over to the MRI. And they don't know why. They didn't. I told them, this is why. If they can't lie flat for a DEXA scan, send them over. They probably have another fracture. And 80, 90% of the time, that's right. So, and that's why. So my follow-up really has to do primarily with the follow-up for the treating the underlying bone density, and it has to do with any time anybody has another fracture, we want to be available for them. That's a very big, high consumer patient population. So let me give you another one. At a physician-owned facility, for each patient, apart from the imaging and everything else, they average $8,000 hospital billed charges within the first 60 days after the kyphoplasty, with everything else excluding the kyphoplasty, primarily because of osteoarthritis and spinal stenosis. So this is a high utilization patient population.
Awesome talk as always, Dr. Beall. I think there's also going to be time for further questions on vertebral augmentation and spinal cord stimulation during the panel discussion. But there's a quick question there. Go ahead.
I was just asking if you do have patients that have these fractures, are you changing the medical management on them and stuff?
The problem is with all anabolic bone agents or all bone agents in general, it's time and grade. It takes a while. The reason I use Tymlos is because it's front-loaded. It's a fast-acting medication. The whole reason for the molecule is it acts faster than Forteo. So I do that. I get on board as soon as I can, and the fracture risk will not go down until month 6 to 8, somewhere in that range. Time and grade, you just got to be prompt about getting on it. Other than that, there's not much you can do. We got a PT with extension training, and I had that protocol prescribed as part of my follow-up, and I do home PT. We also do home health, in addition to the PT, the home health for injection training in the home, so we get it started promptly. But there's not much you can do. You put the full court press on them, calcium vitamin D and anabolic bone agent, and then physical therapy with essential training. These are the only things that have been shown to prevent additional fractures. And even then, it's hard.